Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Mr Kieron Power about pharmacy-led services for the management of venous thromboembolism. Mr Power, why don't you start by introducing yourself?
So my name is Kieron Power. I'm the clinical lead pharmacist for thrombosis and anticoagulation in Singleton Hospital in Swansea Bay University Health Board. Just to give you a brief background to my role, there's three different aspects to my role. So I'm the clinical lead for the VTE service based here in Singleton, out of the acute GP unit, which fundamentally involves me taking quite a hands-on role in the running of the service, along with leadership and direction for the service. I also undertake a once-weekly haematology clinic on behalf of the consultant haematologist here, which is based around me reviewing complex thrombosis and anticoagulation patients. And the third aspect then is around the thrombosis and anticoagulation committee role, in which case I generally develop the majority of the policies and guidelines for anticoagulation in the health board.
I understand that you have built up a VTE service for Swansea Bay University Health Board. Can you give us a brief overview of the service?
So if we go back in time a little bit, so around about 2014, we were initially asked to get involved with the management of VT from the basis of the acute GP unit, which is our ambulatory VT service. And initially we were asked to get involved mainly around dosing warfarin for patients diagnosed with VT at the front door and supporting them to get into range before then being referred on to warfarin dosing clinics. But as warfarin started to become far less commonplace and DOACs far more so, we began to take more of a hands-on role in terms of VT management in general. And so over the past couple of years, we've evolved our service so that we are now the primary clinicians who look after VT in the health board. And what I mean by that is once the patient's been diagnosed with a VT, they get passed to us for a same-day appointment where we will initiate therapy, and the patient then will be under our care for the duration of their management until we make a decision at that 3 to 6 month point, and then we'll either stop the anticoagulant therapy or refer them into primary care.
Thank you. Pharmacy-led anticoagulant services have tended to focus on atrial fibrillation for stroke management. Why have you chosen to focus on VTE?
It's quite an interesting question, and I think to some extent it was maybe organic, and because of the fact that our entry into anticoagulant management was in the realm of VT, there was this organic movement into it. But I found the area quite fascinating, and I do think that although both areas are complex, I think there's far more complexity in VT management than there is in AF management when it comes to anticoagulant therapy. Mainly because I think there's a lot of supporting algorithms in terms of AF management, whereas VT, there's a lot more variability in the type of patients you see, that there's a lot more decision points to undertake as you go along. And as such, it became an area that I thought worked very well with pharmacist independent prescribers. And as our interest grew, the service grew with it.
Is venous thromboembolism a big problem?
Yes, absolutely. I mean, I think we've seen recently with the news around the vaccine and the concerns around thrombosis that it actually made us look at how prevalent VT is in general. So we estimate that it's around about 1 to 2 in 1,000 patients in Europe develop a VT every year. And obviously there's acute concerns in terms of the immediate risks of VT, but also there's long-term complications as well. So it's a far more prevalent condition than I think people actually realize. And as I mentioned, I think the complexity of management is also far more than people realize also. It's not a case of where we maybe used to think that we would just treat people for 3 to 6 months with anticoagulant therapy and that would be that. We're now far more interested in long-term risks of recurrent, long-term complications. And so, yes, I do think that it is quite a serious issue, but maybe the awareness isn't quite there yet.
Thanks, I see. And how would you describe the benefit of your service to patients?
I think the main benefit, as I mentioned, is the fact that you get that consistency of healthcare professional. There's 3 of us currently who run the service as independent prescribers. Most patients will see one of the 3 of us. We all work together, all our development has been together, we make consistent decisions. So the benefits are the patients are under one of 3 healthcare professionals, and we have a very tight system whereby all of these processes are undertaken, and so that they can rest assured that once they're under our service, they will have all of those management decisions undertaken under one roof.
Thank you. I can see that people would find that very reassuring.